Hello, everyone, and thank you for joining us for today's NTI Sunset Session, Full Tank or Running on Empty, Evidence-Based Strategies for Fluid Management. I'm Kimberly Nelson from Baxter's U.S. Hospital Products team. And today's topic is all about critical care nurse decision-making as it relates to fluid administration. A lot of questions still remain about when to give fluid, the amount to administer, the type of fluid to use, and when to stop giving fluid. During this presentation, our expert panel will present the latest evidence to support decision-making on fluid resuscitation and de-resuscitation using clinical signs and symptoms, as well as the latest technology. With that, I'm very excited to welcome our panel, Nicole Kupchak, Kathleen Bowman, and Angela Craig. Welcome, ladies.
Hi, my name is Nicole Kupchak, and welcome to NTI 2021, where we are going to chat about fluids in this really fun and exciting sunset session. I want to say a huge thank you to Baxter Healthcare for arranging this. So a little bit about myself. My name, again, is Nicole Kupchak. I'm a clinical nurse specialist, and I'm an independent critical care consultant. I also work as a per diem clinical nurse specialist at a local hospital here in Seattle, Washington. I've got about 30 years experience. I've been a former Code Blue Chair, sepsis coordinator. I'm the author of 6 certification review books, numerous published papers. And a fun thing I'm doing right now is I'm doing a quarterly column with the American Journal of Nursing called ECG Strip Savvy. And then I'm also a national and international speaker. So with that, I want to hand it over to Angela Craig.
Hi, I'm Angela Craig, and I'm the clinical nurse specialist for the ICU at Cookeville Regional Medical Center in Cookeville, Tennessee. I also serve as my hospital sepsis coordinator, and I'm also on the Sepsis Coordinator Advisory Committee for Sepsis Alliance. I have lectured extensively for numerous conferences and webinars on sepsis and hemodynamic topics. I've also published on the topics of sepsis and heart failure. I'm just really excited to be here. Next, I'm going to hand it over to Kathleen Bowman.
Thanks, Angela. I'm Kathleen Bowman. I'm a clinical nurse specialist, educator, and consultant, and I've published and lectured nationally and internationally on a whole array of topics, but specifically on hemodynamics, sepsis, early recognition and management. And I'm a subject matter expert for the American Hospital Association on a number of those topics. And most recently, I've been appointed as an honorary ambassador to the World Federation of Critical Care Nurses, and I serve as their financial director. So I want to put our disclosures forth for Angela Craig. She is a consultant and on the Speakers Bureau for Baxter Healthcare, Edwards Life Science, and Beckman Coulter. For Nicole Kupchak, she is a consultant and on the Speaker Bureau for Baxter Healthcare and Stryker Medical. And for myself, I'm a consultant and on the Speaker Bureau for Baxter Healthcare and Stryker Sage Medical. So let's get started. Learning objectives. Yes, you got to have objectives if we're going to move forward. What are we going to talk about over the next hour that we have with you? We're going to discuss the implications related to fluid overload or under resuscitation, because both have some negative consequences. Analyzing fluid management using evidence-based research to be able to support critical thinking, decision-making at the bedside, and then demonstrate critical thinking of fluid management concepts through a case-based scenario. So let's rock. We're going to start with a patient, 58-year-old, presented to the ED with a productive cough, fever, and chills. They were given 2.5 liters of LR, IV antibiotics were started, blood cultures, lactate, so it looks like the 3-hour bundle there. CBCs with a differential and procalcitonin was drawn. Vitals after that initial bolus, you can see the heart rate was still elevated. MAP was 60, borderline, respiratory rate 26, SAT 91%, 50% mask, and you can see elevated temperature. So the lactate went down to 3.8 from 4.2. They weighed about 80 kilograms and the patient was lethargic. So I have a question to ask you. What would you recommend for this patient? Would you give another liter of fluid? Start a vasopressor, both fluid or pressor, or I really don't have enough information to decide. Well, we took when you think about it, and hopefully you're chatting there in the box, most would be giving another liter fluid. We've got literally borderline hypotension, patient is still hypoperfused. So how do we know? How do we know if that patient is fluid responsive or if they need a vasoactive? So let's go into Fluids 2021, all you could want to know and we're afraid to ask. No, I'm kidding. I think it's really important to understand that fluids are drugs. And we need to have greater precision in how they are ordered, how they are delivered, and how they are assessed as a part of this journey. So the questions we need to ask around fluids at the bedside is, when do I give them? What are the indications for it? Which fluid should I be giving? How much fluid should I be giving? And is my patient responsive to that fluid? So how much fluid do we give? If we don't hit in the sweet spot, right in that optimal, we're looking at complications of under-resuscitation if we give too little, which results in altered tissue perfusion, acute kidney injury, confusion, multi-organ failure, and circulatory collapse. And on the flip side, if we give too much, lung water, ARDS, and you sort of saw this happen with COVID in the initial, there was a strict fluid restriction for these patients, even though they may have been in septic shock. And what happened is you saw a boatload of acute kidney injury. So it's really a tough balance. We see peripheral edema, that kind of Michelin man, delirium, abdominal hypertension, acute kidney injury, increased ICU and hospital length of stay, and also increased ventilator days. So we've got a couple of studies that show us on the too much fluid, what are some negative outcomes that occur. So this was a large premier database that was evaluated looking at a large number of patients that were with sepsis or severe sepsis or septic shock that were admitted from an ED into the ICU. So they took a look in the first 24 hours, the amount of fluid was given. And what they found is if it was between greater than 5 to 9 liters of fluid in that first 24 hours, what happened? Mortality rate was increased by 2.3% for each additional liter after 5 liters. So just think about the patients that you care for, or you may have cared for in the last week, and the amount of fluid. And this is in that first 24-hour window. Also, they were able to associate increased hospital costs by about $1,000 for each liter greater than 5. So both of those were highly statistically significant. So as my colleague and friend Nicole would say, holy wowzers, excess fluid causes harm. What is the long-term impact of fluid overload? This was a retrospective analysis looking at about 247 septic shock patients. And so they define volume overload as greater than 10% of admission body weight at discharge. So that was how they defined it. What did they find? At ICU discharge, 35% of the patients were volume overloaded. Look at the average volume, 12.5 liters overload. Do you think we could find something in the middle there? And what impact did that have? Well, the challenge was only 42% of the patients got diuretics, so we were not de-resuscitating and getting that fluid off. So the ultimate impact in this was their inability to ambulate at discharge, and they didn't go home. They were more likely to go to extended healthcare facility. So when we look at the 4 phases of fluid resuscitation: rescue, optimization, stabilization, and de-resuscitation or de-escalation. The rescue, I like to equate with that initial, in the sepsis patient, the initial 30 ml per kilogram. But I really believe we have an opportunity to impact at the de-escalation phase, because you saw how many patients didn't get diuretics. But I think a window of opportunity can really happen here once we did the initial resuscitation to then be more specific to the patient by understanding truly the amount of fluid they need and be able to personalize their optimization and make that determination whether it's fluid or vasopressors that they need to maintain perfusion. And so I am going to hand it over to my colleague Nicole to do the next social poll.
All right. Well, thanks for that handoff, Kathleen. So this was a social media poll that I posted a couple of days ago. But which measures do you routinely use to determine if the patient needs fluid? So in the chat, if you're listening to this during the scheduled recording, drop us a note in the chat and let us know what you use at the bedside. But I did a social media poll on Instagram asking this question. And here's what we found. So the question I asked specifically was, your patient is hypotensive. How does your facility decide to treat the hypotension? And 90% of respondents, we had over 6,000 nurses and physicians who responded, and 90% said they use heart rate and blood pressure to determine if the patient needs volume, whereas 10% said they use the passive leg raise test with a stroke volume measure. So really interesting. We're still heavily using heart rate and blood pressure. What do the surviving sepsis guidelines say? And by the way, summer of 2021, we should be getting new sepsis guidelines. So stay tuned to see maybe if the guidelines will change and head in a different direction. But what they say now is if the shock is not resolving, that they suggest a dynamic over a static variable to be used to guide fluid resuscitation. And so really what that means is we should be using a stroke volume measure and not using something that's static like blood pressure or central venous pressure. So bottom line is we need a stroke volume measure. But I think another thing to always clinically keep in mind, like I'm thinking to a patient we took care of last week who had septic shock, for example, and he had a lot of cardiac dysfunction. And so always, remember, if you've got a patient who you're giving fluid, maybe you're starting a pressor and they're still just kind of not looking quite right, always think about the possibility of getting an echocardiogram to assess for cardiac dysfunction. But I think the bottom line when you're administering fluid is that you need some dynamic measure such as a stroke volume measure. And I want you to think about this question. So raise your hand, and I know you're just raising your hand at home, but raise your hand if you've ever given your patient a fluid bolus. We all have, right? We've all done this. We've all done this a gazillion times at the bedside. And when you give your patient a fluid bolus, what do you want to happen? Well, we want the stroke volume to go up. That's what we want to happen. And so really what we're asking ourselves, we should be asking ourselves, okay, where is that patient and the Starling curve? And let's just be honest, like most of us that are healthy any given time of the day would be fluid responsive if you were to assess our Starling curve. However, these patients are hypotensive or hypoperfused. So in that setting, if they're on the bottom portion of the Starling curve, we're going to give them volume. Whereas if they're toward the top portion of the Starling curve, they're not going to be volume responsive. And in that type of a situation, it's time to start a vasopressor to support their blood pressure or assess for cardiac dysfunction. Maybe do they need a positive inotrope? But that's the bottom line. And so what I'm going to do is I'm going to talk through how we can use the passive leg raise test with a stroke volume measure. Specifically, we're going to talk about the Starling device, which is a bioreactance technology. And with the passive leg raise test, we're going to basically challenge the patient to see if their stroke volume increases. If it increases in the setting of hypotension or hypoperfusion by at least 10%, then that indicates the patient would be volume responsive. However, if with the passive leg raise test, the patient's stroke volume does not increase by at least 10%, then it's probably time to start a vasopressor. And Angela's got a really cool case that we're going to go through as well. Now, one of the things that's really interesting that we keep seeing repeat itself in the current studies that are being published is that after there's a good portion of patients after they get their initial fluid resuscitation, they are no longer fluid responsive. But I want you to think about that. How many times clinically would you see a patient just get one fluid bolus and then go straight to a pressor? I don't think it happens very often. However, if you are using stroke volume to guide that, we probably would give a lot less fluid clinically. So let's take a look at some of the literature. So why is blood pressure not a good predictor of fluid responsiveness? Well, I mean, the thing is we've got a sympathetic nervous system and a RAS system that kick in and they compensate when we're in the setting of hypotension or hypoperfusion. And so blood pressure just is not predictive of fluid responsiveness. And there have been a number of studies published over the last 2 decades that are really guiding us away from static measures like central venous pressure, blood pressure, and heart rate, and directing us toward using a stroke volume measure to decide if a patient's going to be fluid responsive. So I've listed a number of papers here that are recent that really guide us in that direction. So we're going to take a deeper dive into a few papers. Now, you might be thinking, well, what's wrong with the CVP? We use it all the time. Or maybe you're thinking, yeah, that's CVP. Why did it go away? Or maybe you're thinking, bye, right? But let's look at some of the data behind it. So this is a study that was published way back in 2000. And this was a study where basically they were evaluating fluid responsiveness, and they were evaluating the wedge, right atrial pressure, changes in systolic pressure, and then changes in pulse pressure. And they compared that to a cardiac output measure. And what they did was they plotted the sensitivity and specificity of each of these measures, which were commonly clinically used. They plotted each of these against a stroke volume measure. And so what they calculated was what's called an area under the curve. So for example, if something scores an area under the curve of a 1, that means it's a perfect predictor. If it scores a 0.9 to a 0.99, it means it's an excellent predictor, but there'll be a little margin of error. If it scores a 0.8 to a 0.89, that means it's a good measure, but there will be a little bit more error. A 7 to 7.9 means it's fair. There's going to be upwards of 30% margin of error. And if anything scores below a 0.7, we really should not be using it clinically to make decisions. So the central venous pressure, which all of us were like diehards, we measured it clinically for years, right? How well does this right atrial pressure, or CVP, predict fluid responsiveness? Well, it scored an area under the curve of a 0.56, meaning it's as good as flipping a coin. And so that's why we've made this big move away from using central venous pressure to guide fluid resuscitation. It's CVP is a huge fail to predict fluid responsiveness. So would there be some conditions or some situations where CVP would be appropriate? And I'd say absolutely. If you've got a patient who's in right-sided heart failure, if you've got a CVP that's climbing, that can help guide therapy there. I actually worked with a nephrologist who said the CVP is the window to the kidneys. If you always have this raspy voice, but meaning that if there's a lot of congestion in the kidneys, you'll see a rising CVP. But in general, to decide whether a patient needs fluid or pressor, that we should not be using central venous pressure. So this table that we put together is compiled from 3 different studies over the past 17 years. And basically what we can identify from these studies is that blood pressure still, and that was reaffirmed in the poll we did on social media, but blood pressure is still the most commonly used clinical indicator to decide if a patient needs volume in the setting of hypotension or hypoperfusion. One thing I want to point out, so you can see this is 2004, 2010, and beyond. And one thing I want to point out is that the use of CVP to decide if a patient needs volume has decreased drastically because we've let the science guide us. We've let the research guide us, and we're not using CVP anymore to decide if a patient needs volume. And that thus was the change in the Sepsis Guidelines in 2016. So what should we be measuring? And the bottom line is we need something that reflects stroke volume. So maybe we're looking at IVC collapsibility with ultrasound. Maybe we're using the Starling device, which is actually what I'm going to talk about right now. There's digit continuous cardiac output blood pressure devices that can be used, arterial line technologies, and tidal CO2. But the bottom line is we need some sort of a stroke volume measure and not blood pressure and heart rate. So one of the big sayings right now in the hemodynamics world is stroke volume the 6th vital sign? I don't know. I'm going to try to convince you that maybe it should be. All right. So bioreactance. So this is a non-invasive method of cardiac output measurement. And basically what we do is we'll place electrodes on the patient's chest. We almost make like a box around the heart. And in 2 different phases, a signal will be sent out and the device will calculate the stroke volume and cardiac output. And so we use this in the setting of hypotension or hypoperfusion to help guide with a passive leg raise test, or you can just give a very rapid fluid bolus. We'll get a baseline stroke volume measure, lift the patient's legs, or we will just, like I said, give a super fast fluid bolus. And if the patient's stroke volume increases by 10% or more in the setting of hypotension or hypoperfusion, then that guides us to give fluid. However, if the stroke volume does not go up by at least 10%, then we're going to start a vasopressor to treat that hypotension. And the one thing I will say though is that when you do the passive leg raise test, or you give a patient a bolus and you identify that yes, they do have a stroke volume increase of 10% or more, it doesn't tell you how much fluid to give. It only tells you that if the patient received fluid, their stroke volume would likely increase. So the passive leg raise test, many of you may have done this clinically, but to do it properly, you need to start with the patient's head of the bed up and their feet flat. So usually we'll raise the head at least 45 degrees. And this is the point at which you want to get a baseline stroke volume measure. And then what we will do is we will drop the head and we passively lift the legs 45 degrees. And I cannot stress enough, it is important to passively lift the legs. If you let the patient help you, that can actually change venous return, which can alter the numbers. So again, this is called the passive leg raise test. So basically what you're doing is you're taking the blood volume from the patient's legs and lower abdomen, and you're giving them a physiologic fluid challenge. A lot of the literature equates it to being the equivalent of about a 300 ml fluid bolus. You want to lift the legs for about at least 2 minutes, and then you want to reevaluate the stroke volume. Now, you don't want to wait more than 3 minutes because you're going to lose a lot of that response. So this is a very fast test that should be done pretty rapidly. Now, there are some limitations to doing the passive leg raise test. So for example, if the patient's got a tight belly with intra-abdominal hypertension or worse yet, compartment syndrome, this isn't the test for them. If they've got ICP issues, a lower extremity DVT, an unstable spine, if they've got venous compression stockings, you should take those off prior to doing the test. If they've had a leg or legs amputated, this is not the test for them. And then finally, if a patient has severe hypovolemia or hemorrhaging, they may not have enough blood volume to displace. So that would be a limitation. So in that case, what you could do, any of these cases, you could just give a rapid fluid bolus and see if the patient's stroke volume changes. So how well does the passive leg raise test predict fluid responsiveness? So in 2016, there was a meta-analysis that was published asking that exact same question. And so what they did was they did a PLR test with some sort of a stroke volume measure. It could have included echo, pulse contour analysis, bioreactance, etc. And what they found was that when the passive leg raise test was paired with a stroke volume measure, it had a very high predictability to identify fluid responsiveness. Scored an area under the curve of a 0.95. So remember, that's an excellent predictor. When the passive leg raise test was used with pulse pressure changes, so basically blood pressure changes, it only scored an area under the curve of a 0.77. So really, the standard of care should be to use the passive leg raise test with a stroke volume measure. So let's dig a little deeper into some clinical outcome studies. So one of the studies that was published in 2017, which was pretty impactful, was done at the University of Kansas. And it was a before and after trial where they evaluated patients who had severe sepsis and septic shock. And what they would do is they had a before group where they would just do usual care, where they would use things like heart rate and blood pressure, lactate levels to decide if a patient needed volume in the setting of hypotension or hypoperfusion. And then the after group, they actually connected the patient to the Starling device. 100 patients were included in that group, and they would use the Starling device to identify if patients were fluid responsive. So what did the study show? Well, a couple things to note is that the patients who had the Starling device actually got an average of 3.5 liters less fluid than the group that was in the usual care. So the usual care arm where they use blood pressure and heart rate and lactate levels to decide fluid responsiveness. And then another signal, we're seeing this again, almost half of the patients who got their initial fluid bolus no longer needed additional fluid. And this is a signal we keep seeing showing up in a lot of studies, which I think is absolutely fascinating because so many times we'll give 2, 3, 4 plus fluid boluses. What else did this study identify? Well, they identified that the group that had the Starling device had almost 33 hours of less vasopressor needs on average. Their need for mechanical ventilation decreased by almost 50% when a stroke volume measure like the Starling device was used. And then the ICU length of stay decreased by 2.8 days when a stroke volume measure was used. So from this sprung the FRESH trial. So FRESH standing for Fluid Response Evaluation in Sepsis, Hypotension, and Shock. This was an international trial that included 13 US and UK hospitals. It was a non-blinded randomized control trial. It'd be kind of hard to blind whether a patient was getting a stroke volume device hooked up to them. But 124 patients were enrolled, and it was done in a 2-to-1 enrollment, meaning 2 patients received a stroke volume measure for every 1 patient that received usual care, where they would use things like heart rate, blood pressure, et cetera, to decide fluid needs. These patients were enrolled very early after presentation in the emergency department. And that's the key, is you don't want to enroll a patient once they've received 6, 7 plus liters of fluid. You want to do it after that initial fluid bolus. These patients had refractory septic shock, and they had to have received less than 3 liters of fluid. So this is a study protocol. And one of the things I love about the study protocol is I think it's a really easy protocol to use practically in a clinical situation. But what they would do is they would ask themselves, is this patient hypotensive or hypoperfused? So do they have a MAP less than 65, a systolic less than 90? Or is the blood pressure rapidly trending lower? Do they have low urine output, or do they have some other clinical indication to administer a fluid bolus? And so what they would do, if the answer was yes to any of those, they would do the passive leg raise test. If the stroke volume went up by 10% or more, they would give fluid. If the stroke volume did not go up by 10% or more, they would either start or titrate a vasopressor. And the one used most commonly was norepinephrine. And they would do a consistent reevaluation if the patient remained hypotensive or hypoperfused. So they would, every time they did an intervention, if the patient was still hypotensive or hypoperfused, they would repeat the passive leg raise test and reevaluate the stroke volume change. And so I have to say, the results of this study, to me, were pretty mind-blowing. They followed these patients for the next 72 hours or until ICU discharge. And what did they find? Well, the primary endpoint of this study was to identify, did we give less fluid if a stroke volume measure was used to evaluate fluid needs? And the answer was absolutely. So the treatment group, those who got the Starling device, got on average 1.37 liters less fluid than the group who served as the control group. So really interesting results, which I'm not surprised by this, just clinically working with these types of devices. But I think this really kind of gave us some solid objective data to steer us in the right direction. So the secondary endpoints were pretty impressive. The need for renal replacement therapy or dialysis was decreased significantly in the treatment group. So you can see the treatment group, 5.1% needed dialysis versus the control group, 17.5 needed dialysis. And that did reach statistical significance. The need for mechanical ventilation, we saw the results repeated in this trial again, where you can see almost half the patients needed mechanical ventilation who had a stroke volume measure used. So you can see the treatment group, 17% needed mechanical ventilation versus the control group where 34% needed mechanical ventilation. And that did reach statistical significance. ICU length of stay, the treatment group was 3.3 days versus the control group, which is 6 days. Now, this did not reach statistical significance, but let's be super honest. If we are shaving off 3 days length of stay in the ICU, is that clinically and financially significant? Absolutely. And then finally, more patients were discharged home when a stroke volume measure was used to guide fluid. And you can see 63.9% of patients went home who had a stroke volume measure versus only 43.9 in the control group. And that, again, did reach statistical significance. And I have to say, this trial, a lot of us were anxiously awaiting the results of this trial. And it's pretty compelling. It's pretty compelling that we should get away from using heart rate, blood pressure, and non-dynamic measures to make decisions on fluid in patients who are hypotensive or hypoperfused. So a cost analysis was done after the University of Kansas study. And what they identified was that patients who had a stroke volume measure ended up with a $14,500 cost savings per patient. So I know, like, one of the questions I'll get a lot of times, well, how much does that thing cost? Well, let's just be honest. You put a couple patients on this, you've paid for the device and cost savings. And so, I really think it's always important when we're bringing in new technologies to understand the potential benefits beyond the cost of the device. So with that, I'm going to hand over to Angela Craig.
Well, thanks, Nicole. And I'm going to share with you guys a case study, and we're going to really go through how we can do this for a patient who is in our intensive care unit or even in the emergency room, right? This can be utilized there as well. So let's get started. So we have a 56-year-old male who arrives from the emergency department to the ICU with septic shock. The diagnosis of UTI was made due to a blockage from a kidney stone. And they did give him some Tylenol down there because he was running a fever. And past medical history is that he does have a history of heart failure. Ejection fraction is 35%. They did have to intubate this patient, so he was mechanically ventilated. And they did do the 3-hour bundle. They obtained the lactate and blood cultures, and the patient did receive broad spectrum antibiotics and the 30 ml per kg of fluid down in the emergency department. Blood pressure on arrival to the ICU, you can see our mean arterial pressure is 57, temperature is high at 101, heart rate elevated at 120, lactate very elevated at 12, white count elevated at 26,000, BUN 20, creatinine elevated at 2.6, and our procalcitonin is elevated at 5. So our question, just like Nicole has been talking about, is this patient hypotensive or hypoperfused? So a Starling device was applied to assess stroke volume changes with the PLTR test. Once we applied the Starling device, it was noted that the patient's stroke volume was 38, cardiac index 2.5. And let's back up and say that that stroke volume is low. We think of normal stroke volume right around 60 to 100. Cardiac index is 2.5. TPR is low at 600. Temperature is still high at 101. Heart rate elevated at 120. And like I mentioned, our mean arterial pressure is low at 57. So we did a passive leg raise to assess stroke volume changes. So you can see that our stroke volume went from 38 to 39. So it only went up by 1. If we were expecting a 10% increase, it would need to go up by about 3 to 4, 3.8, closer to 4 stroke volume increase. But we only had a 2.6% increase with that passive leg raise. So that should tell us that that patient most likely does not need volume. Now, you can look at the cardiac index, it's 2.5. You can also see that the TPR is still low at 650 and heart rate's 121. Blood pressure is still low at 56, the mean arterial pressure. So based on our clinical findings, what should we consider next? Well, do we want to give a vasopressor? Do we want to add an inotrope? Do we want to give more IV fluid? And let's look down here at our device. This is what a Starling device looks like. And after we've done a passive leg raise, you're able to see the results. And you can see that this patient is not fluid responsive. Or do we want to give a vasodilator? And let's think long and hard about the vasodilator because we already have a mean arterial pressure that's low at 56. So feel free to put in the chat box what you guys would do. And we are going to suggest we would start a vasopressor. Norepinephrine is the vasopressor of choice, as we know, for our septic shock patients. So this vasopressor norepinephrine was started. Now, we started the patient at about 5 mics per minute. We increased over the next hour to a 20 microgram per minute. And so now I want to look at the pre-PLR numbers. Now, our question to ask is the patient still hypotensive or hypoperfused? And so you can see the pre-PLR stroke volume is still low at 46. Our cardiac index is 2.1. TPR is still low at 675. Temperature did come down a bit. We're grateful for that after some Tylenol. Heart rate's down a bit to 115, but our mean arterial pressure is still only 60. So are we hypotensive or hypoperfused? That answer is yes. So let's think about what we should do next. Hopefully everybody thought we should do a PLR because that is exactly what we're going to do. We're determining if this patient is volume responsive or not, now that this vasopressor is in place. So it's not just like you do one PLR and it's one and done. You're literally evaluating once you put on the medication, if that's what's needed to determine, hey, will they maybe have a volume response now? So you can see stroke volume went from 46 to 48. I've done the math for you. It's only 4.3% increase. So we know we are not volume responsive. Cardiac index is down to right about 2.0. TPR is 675. And you can see heart rate 110 and mean arterial pressure is still low at 59. So when we did do the passive leg raise test, you can see the blood pressure actually went down a bit. So based on our clinical information presented, what should we consider next? Do we want to increase our norepinephrine? We're already at a pretty high dosage. Do we want to add another vasopressin? Do we want to give an inotrope? Do we want to give more IV fluid? Or do we want to give a vasodilator? And you can see also down here is very similar once again to what that slide would look like or the screen would look like after we did a passive leg raise. And you can see here that the patient is not volume responsive. So we are going to add another vasopressor and we are adding vasopressin. So pressor 1 is norepinephrine. So and it's going at 20 mics per minute. Pressor 2 was added, vasopressin at 0.04 units per minute. Now, pressors did continue. Blood pressure improved for the next hour. MAP came up to greater than 65, and our TPR improved. And remember, with our TPR, we're not as constricted. When it increases, we are a little more constricted. So you can see as we're adding those vasopressors, you're going to see, or you should see, an increase in your TPR with that medication as we're adding it, a little more constricted. Now, lactate decreased to 5. After an hour, our cardiac index, though, dropped to 1.9 and our stroke volume decreased. Now, we are going to do a passive leg raise test to see if our patient's fluid responsive. Notice we only had a 2 increase from 40 to 42. That is a 5% increase. Cardiac index is still low at 1.9. TPR is pretty decent at 925, more constricted. Heart rate is 100, and my mean arterial pressure is 68. Now, the question is my patient still hypoperfused or hypotensive? Well, the mean arterial pressure is good, but look at this cardiac index. So I'm still hypoperfused and not hypotensive right at this moment, but there are things that are not right with my patient that would make me worry to feel that they are hypoperfused. Now, based on this clinical information, what should we consider next? So we know that this patient is not volume responsive. You can see it right here. Are we going to increase norepinephrine? Are we going to add another vasopressor? Are we going to give an inotrope, give more fluid, or give a vasodilator? Feel free to put those answers in the chat box. And we are going to add an inotrope. You can see that this patient's cardiac index is less than 2.0, so we are definitely worried about this patient from a contractility standpoint. So norepinephrine, vasopressin, and dobutamine continue. Patient's cardiac Cardiac index improved, as well as the patient stroke volume, as you can see over here. We put it in red. We've gone from 40 to 55 1 hour post-dobutamine, and we've gone an index from 1.9 to 2.5, all things that we would hope to see. And if you didn't have this technology attached to the patient, you would not have any idea where you're at, right? So it's really nice to have this at the bedside. Now, is the patient still hypotensive or hypoperfused? And honestly, based on this information I see, I'm going to say no, and we're going to hold for now and just enjoy the moment where we're not having to tweak something, but we're going to consistently look and be monitoring to see if anything changes. Well, of course, we're in ICU, right? This is where patients are unpredictable. So 2 hours after that dobutamine is started, patient's blood pressure began to drop. It went down to a MAP of 56. Stroke volume went from 55 down to 50 mils per beat. Our current infusions are 3: norepinephrine, vasopressin, and dobutamine. And our question is this patient hypotensive or hypoperfused? And yes, we feel like they are. We know they're hypotensive, as their mean arterial pressure is only 56. So what are we going to do? You guessed it, a PLR. So we did another PLR just to see if the patient, now that they have those 3 agents on, are they fluid responsive? And lo and behold, after all this time, our stroke volume went from 50 to 57. That is a 14% increase. Cardiac index went up to 2.6. Our TPR is up to 925. And heart rate is still just a little tacky at 109. But my mean arterial pressure did come up. It's still a little low, but it did come up to 59. So based on this clinical information, what should we consider next? So norepinephrine increase, another vasopressor, another inotrope, give more fluid, or hold tight. And as you can see, this is a real good screen example on what it looks like after when you're using the Starling, when you've done a passive leg raise and they've had a positive or a good fluid response. It does say the patient is fluid responsive. All right, so let's all vote. And hopefully you voted give more IV fluid. And I agree with that 100%. Now, the patient was given a bolus of fluid based on that stroke volume response. We saw that it went from 50 to 57. And after 500 mils of lactated ringers administered, the new vital signs are listed. So we went from a stroke volume of 57 up to 63, a cardiac index of 2.7 to 2.9, TPR of 925 to 950, heart rate's 105, and our mean arterial pressure is 71. So what would we like to do? Do we want to increase norepinephrine? Do we want to add another vasopressor? Do you want to add another inotrope, give more IV fluid, give a vasodilator, or hold tight? And I hope you all picked hold tight, because right now this patient's looking pretty good. Now, this is just a summary of all the interventions we've done over that period of time, all the way from the emergency room to after that last fluid bolus was given. Pretty impressive. And this just shows you how it's so helpful to know what your patient's stroke volume is and how they're responding, as well as the other parameters as well. Now, thoughts on this case? I think it's important to think about stroke volume. Stroke volume changes guided fluid administration. It can make a tremendous difference in how we care for our patients. Also, guessing or basing fluid administration on heart rate and mean arterial pressure, that can lead us in the wrong direction, just like Nicole was sharing with us. And taking the time to evaluate patients' individual hemodynamic status can help us to really individualize care and make the best choices for our patients. And I think that's really what we all want. Now, I wanted to share with you just a few more items that we use here at my institution. And these are some of our cheat sheets, but this is our goal-directed therapy protocol. And looking at our algorithm for is the patient hypotensive or hypoperfused and how we do that. I think it's so important that we not only think about increasing fluids for stroke volume, or increasing fluids based on our stroke volume, but also monitoring that for a stroke volume reduction. I think de-resuscitation is very important as well, and that can really help you there as well. Also, I'm all about a nurse-driven protocol, and I'm happy to say that we have a nurse-driven protocol here in my ICU, where if I'm walking around the unit or doing rounds and I notice a patient's not doing well, they're hypoperfused or hypotensive, I can say to the nurse, hey, let's add some technology to this patient, and let's really know how we can better optimize individually for this patient. So at this time, I'm going to hand it over back to Nicole Kupchik.
All right, well, thanks, Angela. I think that was just a perfect example of just how you can use a stroke volume measure to guide resuscitation. I mean, how many of you would have been tempted to give more fluid early on, right? And really that patient didn't need it. So, it's really exciting. Hopefully you gained a few things. We've got some time. We're going to actually have a little discussion here, but I did want to let you know there are some ongoing fluid trials that are really interesting. So kind of just stay tuned. But the PLUS trial is evaluating saline versus balanced fluid as a resuscitation fluid. And then the CLOVERS trial, which is out of the PEDAL network, or which used to be the ARDSNet group, they're doing a study where they're comparing restrictive versus more liberal fluid therapy in patients who have sepsis. And the BASICS trial, that one actually just wrapped up. And I'm really excited to see what the results of that are. But they're looking at balanced fluid versus saline at a rapid versus slower infusion. So, stay tuned. I think now it's like finally, so many decades, we just accepted that this patient is the Michelin man or the Michelin woman. And we just kind of like normalize that practice. And now we are really starting to realize the massive detriments of fluid overload, but also fluid under resuscitation as well. But I think the key take-home points from this presentation is that we need to use some sort of a dynamic measure, ideally with the passive leg raise test and septic shock. We know it's safe. We absolutely know it's safe. We know it reduces fluid balance at 72 hours. We know it reduces the total amount of fluid. And all of that leads to less mechanical ventilation, less dialysis, and more patients making it home. And let's just be honest, I think that's the bottom line. But I think the other big thing was the cost savings that was demonstrated in the University of Kansas study. So we're seeing this in the KU study, the FRESH trial, and then there's a plethora in the surgical literature as well. So we just want to challenge you to think of fluids as a drug. In the same way you'd get a glucose and dose insulin, in the same way you would titrate norepinephrine to blood pressure, you should also titrate fluid to fluid responsive needs. Just understanding what is the heart going to do with that fluid. All right, so in conclusion, fluids are a drug. Think of them as a drug. They need to be dosed appropriately. Under and over resuscitation is detrimental. We need to stop guessing. Bottom line, we need to stop guessing, and we need to stop using things like heart rate and blood pressure to guide fluid and use stroke volume measures. And now I'd like to be rejoined from the team. I don't know, what do you guys think? We have a few minutes to chat.
Well, Nicole, I wanted to share with you, there's a group of us that have done a national survey, and some of the results are trickling in. And what we found in the ICU nurse population, very similar to your social media, that blood pressure, heart rate, urine output. I was excited to see a little bit more. I think that we were at about 20% on the dynamic measures, the PLR and stroke volume.
Okay.
So it was a little higher than what your poll showed. And so this was a tool where we put it through AACN to get critical care nurses to respond, as well as med-surg nurses and others. So look forward to that abstract and full presentation of that data coming out soon.
Yeah. Well, Kathleen, that's awesome. And do you plan to publish those results, Kathleen?
Absolutely. Absolutely.
Oh, cool. Okay.
The abstracts
Stay
will be,
tuned.
the abstracts will be starting, and then the publications will follow from that.
Wow. And I think it'll just be good to get a handle on what is the clinical practice out there.
Well, I think it's important in order for us to create a bench of where we need to start and really focus our education, adding it to our orientations, adding it to our protocols in our unit environments. So really starting to change that culture
Yeah. Now, Angela, I wanted to ask you about your nurse-driven protocol because I think this is absolutely key. We have a non-invasive device. We don't necessarily need to, well, we don't, not necessarily, we don't need to wait for a provider to be at the bedside or to be contacted. What drove you and your facility to implement a nurse-driven protocol? And what positive changes have you seen from it?
Yeah, well, I think it really just empowers the nurses. And, I'm all about giving the nurses tools to help better care for their patients. And I think that sometimes you just have to go through the rigorous task of getting it through committee and getting it approved. And so we were able to get it approved by saying, we will notify the provider of those results. We don't want to keep them to ourselves anyway, but we want to have the liberty. If we think that patient needs it, we don't have to run and ask a doctor, right? We're an intensive care unit. So we are going to go and get that patient on the monitor. We can do a passive leg raise. We haven't protocolized fluid yet, but at least we can do a passive leg raise, and then I can go and speak to the provider, or they can go and speak to the provider, and they're able to use intelligent information to say, hey, we just did a passive leg raise. We had a 10% increase in our stroke volume. Would you like me to give a fluid bolus? So I just think it really does help. And we have been able to give fluid to patients who needed it, not give fluid to patients who shouldn't have it, where normally maybe we would have just given it.
It really allows precision and the nurse's ability to advocate for the right thing with a greater amount of data, which is critical.
Absolutely.
Yeah, and my goal, I'm hoping to retire in the next decade. My goal is to denormalize massive edema in patients. Truly, we've just accepted, they look like the Michelin man, Michelin woman. Oh, they're only 20 kilos up. Are you kidding me?
Yeah.
There's a lot of complications of that,
Yes.
Very true.
All right. Well, I just want to thank you both. You both are always so amazing to work with. I want to thank you both in preparing this. Hopefully, what I am really hoping was an awesome sunset session for all of you who attended. And I just want to say one more huge thank you to Baxter for supporting this. So, all right, keep on doing what you're doing, everyone out there.
Don't forget, guys, our emails are on the bottom for a reason.
Yes.
If you have questions that we weren't able to answer in the chat box, please don't hesitate to send us an email.
All right. Thank you so much.